Thank you very much, Bob. I will talk about the ALT flares and to what extent they could be improved or could be associated with improved virological clearance. Here are my disclosures. And the content of my talk is that I'll talk mainly on flares and PEG interferon and nukes, on nucleoside analog discontinuation, which I could almost skip because there's been a lot of talk about that, and there's some overlap of slides, as you will see. And then lastly on flares in new treatment for HBV cure. So ALT flares are not well defined. I've done several of these studies and they're not so easy to do. The definition also depends really on the frequency of sampling. So for instance, in the natural history of the disease, where patients are only seen once every half year, it's extremely difficult to pick up a flare. But in well-monitored patients, particularly patients in trials that are monitored every 4 to 8 weeks, there are different definitions out there. Typically, what people look for is a serum ALT increase of 2 to 3 times from baseline or nadir, and an actual ALT value of at least 3 up to 10 times the upper limit of normal. ALT flares are associated with hepatocellular damage, and in some situations, as we've seen, they may herald a transition from active to inactive HBV disease. And flares are not well studied. As I mentioned already in the natural history, they're very difficult to pick up. Sometimes they're only partially picked up. You pick up the tail of a flare, but it's you really don't know when they come. That's the problem. The best model is probably stopping treatment, because there you know that a certain amount of patients will have a flare within half a year to a full year. The other reason that we do less flare research is that we don't use a lot of PEG interferon anymore, for good reasons, but PEG interferon is associated with flares much more than nukes are. And then early start of treatment is another problem. We definitely do it, but when the flare occurs, ideally from a scientific viewpoint, you just want to see what happens and do nothing, but it's undoable in the clinic. It wouldn't be ethical, so we cannot do that. And the last reason is there's no good animal model. So it's not so easy to do this type of research. If you look on the immune mechanisms of a chronic hepatitis B flare, HBV is a non-cytopathic virus, and HBV-associated liver disease pathogenesis is largely immune-mediated. And we know that there's a critical role for T cells in animal models, in particular CD8 cells, that kill or cure infected hepatocytes, with a regulatory role of CD4 cells and neutralizing antibodies produced by B cells. And again, due to the challenges in the clinical studies and the limited model systems that we have, it is really unknown what triggers the flare. There's a lot of, if you look at NK cells, the trail expression, etc., there's a lot of studies out there, but to really point out this is what causes a flare is very difficult, and they're obviously, they're probably multifactorial. And anyway, both the innate immune effector and regulatory pathways will participate in the pathogenesis. So let's look at some of the interferon-induced flares, and these are studies going back 14 years, but to pick them up nowadays in the setting of new treatments is not a bad idea, because they're, I think, generally well-performed studies, and this is kind of the first time that we described what we called host-induced flares, or you could call them good flares, but I think the best term is probably antiviral flares, where truly you see that the, I don't know, is there a pointer? Is this working? Yeah. Where you truly see that this is interferon treatment, that there is a significant flare, and at that time the HBVDNA goes down. This is really what we want to see. This is a patient being treated with PEG interferon and lamivudine. This is PEG interferon only treatment, and here you see that once the treatment is stopped, you see the virus going up, and that causes a flare, and we call that at that time virus-induced flare, or you could call them pathogenic flares. Overall, we saw in this particular study 67 flares in 266 patients, with 36, about 1/3 of these flares we call host-induced, 38% virus-induced, and 26 were indeterminate. So that's important to realize. As if you go to the next slide, you see that particularly the host-induced flare much more often led to a treatment response as opposed to the virus-induced flares and the indeterminate flares. And also interestingly, 33% of these flares, which were host-induced, led to S antigen loss. Another important factor was really the timing of the flare, and this is only true for PEG interferon. You cannot translate this to stopping nukes, which I'll tell you later. Particularly if the flare occurred very early, or early on, let's say in the first 32 weeks, it was much more effective than if it occurred later on. And thirdly, the magnitude of the flare was also important. So the mean maximum flare of patients who responded, so the response was E antigen loss here. It's not S loss because we didn't have enough patients. But in those who responded, it was 20 times the upper limit of normal versus those who did not respond, it was 13 times the upper limit of normal. Another analysis that we did, and which is, I think, kind of interesting because we haven't talked about HBV genotype yet a lot, is that we looked at the different genotypes in this study, which was initially published in The Lancet, and we were lucky enough to have all of the genotypes represented. And in the left panel, you see that the amount of flares in the different genotypes is kind of similar, yet the genotype A patients seem to have more on-treatment flares and also seem to have more effective flares. So that's something to take into account and to sort out. So let's look at the flares during nucleoside analog treatment, and those are very rare. If they occur, it's typically patients who are non-adherent. Here in this particular study, we studied in the VIRGL cohort with several colleagues from Europe at the time, flares in 729 patients. And you can see now I have to go back. Is that problematic? Can you help me out?
Press the red button.
Oh yeah. You see that in the E-positive patients over 5 years, roughly 10% of the patients developed a flare as defined by 3 times an increase of ALT and an ALT value of at least 3 times the upper limit of normal. And in the E-negative patient group, it was only 2 to 3%. So very rare. In 2 cases, there was resistance. In 1 case, there was non-adherence. And these were the different patterns that we described. We described also in this case, we saw a few patients, but it's extremely rare in patients being treated with nukes, what we call host-induced flare, so a kind of interferon type of flare with an ALT going up and an HBVDNA going down. Much more often we saw virus-induced flares, particularly in the setting of resistance. And then and that's also something that we have to take into account, and it hasn't been touched upon yet. We have patients with NASH, we have patients with other liver diseases where the ALT is just driven up by something else, or medication or whatever. So in this case, there was an indeterminate flare potentially caused by NASH. Well, you've seen this slide already 4 times, so I'll not dwell on it too much, really. So basically what we want to do with stopping treatment is create a kind of acute on chronic hepatitis B. So you create an acute hepatitis, hopefully, and that will do the job. And the question is, how much S antigen loss will that result in? And yeah, some people are giving the numbers of around 20%, but if you look at these studies, which are mostly retrospective and mostly pretty small, it's a certain percentage after a number of years. But if you look at by far the biggest study, which was done by Dr. Yang from Taiwan with almost 700 patients, the estimated annual S loss in this group of patients was 1.8%. So it's very, very low in this case. And in some, I mean, if the patients are older or Caucasian, it might be better. And we've talked about it extensively, and we need more research on that. So in the Toronto STOP study, we also looked at the flares, and the cumulative rate of off-treatment flare was pretty high, with 61% eventually. This is longer follow-up, an ALT of above 5 times the upper limit of normal, and half of the patients 10 times the upper limit of normal, so it's pretty significant. And as already mentioned, particularly the flares where the HBVDNA goes up very quickly at a high level in 4 to 6 weeks, when the HBVDNA goes up very quickly, that is really a situation where it predicts flares, some of them with very high ALT values, and these patients may need more intensive follow-up and earlier treatment. In this study, we could find no relation between S antigen decline and the flare, but we had very limited S decline altogether, actually, in this study. Another study which looked at the profile, and this has been shown already before, which looked at the profile of HBVDNA and ALT in patients with S antigen loss, did show no true relation between the flare itself and also the magnitude of the flare and S loss. So as opposed to interferon, where most of the flares seem to do something good for the patient, in stopping treatment, the flares are maybe not so good and do not result in more response or more S antigen loss. So S loss not associated with severe flares in stopping treatment. Risk factors for dangerous withdrawal flares, and I think this is important, and all of the drug developers in the room probably know this, but I state it again. Be careful with patients who have advanced fibrosis. The retreatment policy is highly important, whether you have a lot of risk. If you retreat very quickly, you have less risk, but you might also have less S loss. We really don't know. The serological status where you stop the treatment, if thus far, both in interferon-treated as well as in nuke-treated patients, once you have S loss, you're very safe. If the patient is E negative, you're less safe, and if the patient is E positive and you stop treatment, you're even more less safe. Then the absence of anti-E is important. The rise of the HBVDNA, as already mentioned, the amplitude of the flare, but even more so the area under the curve of the flare. So in my view, the flares which linger on for a longer time point, where you don't have this, but you have kind of this, are even more dangerous, and obviously comorbidity plays a role. So what about ALT flares in novel treatment? This is the last part of my talk. And I told you that good and bad were not the right terms, so maybe I should change that here on this particular slide, but they're good slides, good flares, which have an ALT flare due to a host immune clearance accompanied by a decline in HBVDNA and viral proteins. Then there are flares due to enhanced viral activity, and the worst flares are the flares due to an undesired effect of a drug, either autoimmunity or drug-induced liver injury. And the potential reason for ALT flares related to novel antivirals could be separated by direct antivirals, so DAAs and immune modulatory agents. And you probably all know this: stimulation of the immune system related to viral suppression leading to on-treatment hepatitis flares are seen in the DAAs, and hepatitis reactivation and flare after stopping treatment. Drug resistance is something we have to take into account with these compounds, and drug-induced liver disease. In the immune modulatory agents, where potentially, I would say, the therapeutic window might be more narrow and the response might be more heterogeneous than in the direct antivirals, the hepatitis flares can be due to immune clearance of virus during the treatment. It can also be, the flare can be related to insufficient HBVDNA suppression, and it can be immune-mediated with autoimmune effects like in checkpoint inhibition, as we've seen in the field of cancer, and it can be due to DILI as well. So this is kind of a similar slide as what Fabienne showed already. So if we're talking about immune-mediated flares, which is the flares that we typically would want to see and carefully want to follow, they tend to happen earlier on. They're usually self-limiting within weeks. They happen after HBVDNA decline, or HBVDNA decline happens very quickly after the flare, but you should see some DNA or S antigen decline, preferably in these patients. Alkaline phosphatase and bilirubin are usually normal, and a biopsy is typically not needed. If you would have an autoimmune hepatitis flare, for instance in the setting of a PD-1 blocker, they tend to be a bit more fast and progressive and respond to steroids. They're unrelated to DNA. ALP level remains normal. Bilirubin can be elevated. And then there's let's say, typical DILI, which is, I would say, a different animal from the autoimmune hepatitis category, where the flare can happen at any time. They can be static or progressive. unrelated to HBVDNA tend to have more cholestasis and more often a bilirubin, which is elevated, and we know Hy's law to use that in drug development. So the question is, when we have an antiviral versus a pathogenic flare, can we relax if we see an ALT, let's say, of 10 times the upper limit of normal, if there's no hepatic decompensation in the setting of a new drug? And I don't think we can. We should be very careful. And this whole drug development exercise is kind of a minefield that we have to walk through. The way to reduce the risks is definitely to exclude patients with advanced liver fibrosis by transient elastography or APRI score, FIB4, whatever you want to do. We need to evaluate the viral markers to confirm the antiviral flare. We really have to be on top of that. We need to frequently monitor the liver functions and the ALT, that is a given, and we can consider stopping the new therapy temporarily, and if the ALT goes up quite a bit, and recommence potentially after the ALT goes down. So in conclusion, ladies and gentlemen, due to the challenges in the clinical studies and limited model systems, it's very difficult to know what exactly triggers an ALT flares. Flares in PEG interferon seem to be related mostly to E antigen loss or E antigen decline and S antigen loss or decline. Flares during tenofovir and entecavir are mostly due to non-adherence, but these flares are very rare otherwise, flares on treatment really. Withdrawal of nucleoside analog frequently results in ALT flares which do not seem to be related to sustained virological response or S loss. And for new compounds, it is very important to differentiate an antiviral flare versus a pathogenic flare versus DILI. And yeah, we have to take flares into account when stopping combination therapy, including nukes. And we discussed about when to stop and to have a nuke-only arm and stop treatment there. I personally think it might be better to only stop these treatments if the patient, the underlying nuke treatment, if the patient becomes S antigen negative, and otherwise just continues these antivirals, these nukes as a background therapy. Thank you very much.